talk today is on advancing psychiatric practice in higher education. I don't have any relevant disclosures to discuss. We're going to go through a couple topics related to trends of mental health symptoms and diagnoses on college campuses, and then talk about how we've adapted our clinical service to meet those. I'll also talk about a specific effort that we've made to reach a particular student group. The primary source for information about the college mental health experience or university mental health experience is through online volunteer self-report surveys. There's two major student surveys, the Healthy Mind Study, and then the National College Health Assessment, which is put on by the ACHA, the largest professional society within college health. I'm going to focus more on the Healthy Mind Study because it includes graduate students in their sample. There's also information that can come from counseling center surveys, but I'm not going to be presenting on that because college counseling centers can be so heterogeneous in their scope of practice, their resources, and the students that they aim to meet that it's a little bit more to wade into than some of the self-report studies. So the Healthy Mind Study is an annual survey that's an opt-in electronic survey. It comes via an email invitation. And this includes a number of screening tools for clinical experience, but also it has questions about how folks relate to the services that are available to them, how much they know about them, and also attitudes, kind of questions related to stigma. Last year, Healthy Minds received responses from almost 85,000 students from 500 universities. Over the last 18 years, since the inaugural edition in 2007, the Healthy Mind Study has shown a pretty dramatic trend about the increase in depressive symptom screening, suicidal ideation, anxiety symptoms, as well as a higher rate of positive screens for eating disorders. There's also a decreased self-report sense of thriving among college students who responded to this survey. I'm going to quickly go through a couple of these graphs to demonstrate this trend. The first one here shows the positive depression screening with a PHQ of 5, or PHQ 9 of 5 or greater. And you can see this trend increase over the past 18 years. Specifically, the question about in the past year, did you ever think about attempting suicide? You can see that the response rates have doubled since 2007 from about 6% to 13% in 2024. The GAD-7 was used to assess anxiety, and we can see that there's been an increase in both anxiety symptoms as well as severe anxiety, indicating by a GAD-7 of 15 or greater. I'd like to point out that the number of respondents in 2013 who had a 10 or higher on their GAD-7 is the equivalent rate to respondents in 2023, just 10 years later, who had a response of 15 or more. And as you can see on this last slide, there's about a threefold increase in respondents reporting that they take a psychiatric medicine. Now, this isn't exclusively as prescribed by psychiatrists, but also includes folks who get them from primary care services or telehealth platforms. Despite this increase in respondents taking a psychiatric medicine, we are seeing a widening treatment gap. If we look at data of folks who screened positive for one or more mental health condition by the Healthy Mind Study, you can see that this trend increases across different ethnic identities. But Lipson's group, they published this in the Journal of Affective Disorders just 2 years ago. They actually found that the engagement rate for this same group has not been increasing at the same rate. So you can see the dotted lines represent folks who screened positive for one or more mental health condition and the percentage of them who were in therapy in the past year. I'm going to highlight the orange line, which represents folks who identify as Latinx, on this next slide and juxtapose, and you can see this gap widening. We have an increased rate of folks who are screening positive for one or more mental health symptoms but not engaging in treatment. So the big takeaways from these self-report surveys suggest that symptoms of mental health conditions are high and rising among this population. that this treatment gap exists and is widening for students of color, because we do see similar graphs if we look for folks who identify as Native American or Indigenous or BIPOC. The NCHA does a really good job of highlighting the experience of gender nonconforming and transgender identifying individuals. And those folks have a higher rate of mental health symptoms, including suicidal ideation, to almost 1 in 3 respondents with those identities. The picture on the right, or infographic on the right, will show you or illustrate how mental health challenges are affecting people's academic work. You can see that to the question of, in the past 4 weeks, how many days have you felt that emotional or mental health difficulties have hurt your academic performance? 45% responded 3 or more days, and 22% said at least a day and a half per week they feel that their academic efforts are affected. If we were to focus a little bit more on medical students, we would find that this is a group who are screening positive by self-report at a rate of 27%. This is from a meta-analysis of 183 studies. They had different thresholds, primarily using the BDI of 10 or higher, but some used a threshold of 21 on the BDI or a PHQ-9 of 10 or more. Of those cohort who endorsed a positive screen, only 15 to 17% of those were receiving care, and 11% endorse suicidal ideation. That last metric uses a varying timeframes as well. Some folks reported SI within the past 12 months, some in the last 2 weeks, depending upon the different study. Cross-sectional studies have also highlighted that there are some times in medical school that it seems like there's an increased rate of depression symptoms, particularly towards the end of the first year as compared to the beginning of the first year. But also medical students in the 3rd and 4th clinical years are screened higher for depression scores than those in the preclinical stages. While this next slide looks specifically about physicians and not medical students, I think it's important to highlight this cohort. This, I think most folks here are familiar with, but this was published earlier this year in JAMA Psychiatry. Mukija and their group looked at psychosocial autopsies for 569 completed physician suicides between 2017 and 2021. 2 things that they found were that female physicians had a greater rate of suicide per 100,000 than the general population of women, while male physicians had a significantly lower rate than the general population of completed suicide. Considering the findings of the psychosocial autopsy, you can see that there's a number of factors or circumstances that were much more common in the physician profile who completed suicide. They would be highlighted on the bottom of the adjusted odds ratios towards on the right side of your screen. But you can see more commonly associated completed suicide with job problems, depressed mood, or mental health problems. Related to the job problems, I think it's important for us to also consider burnout. Dearby's group in 2014 took 3 different cohorts, medical students, residents, and fellows, and then early career physicians within 5 years of completing their training. And they sent them a number of inventories, including this 22-item burnout inventory, depression screening, and a linear analog scale to rate one's physical fatigue. And they matched them with college-educated, age-matched controls. Those p-values relate to each individual group's specific control group. And the medical students, residents, and fellows, and early career physicians all rated higher in the 3 subscales of the burnout inventory: emotional exhaustion, depersonalization, and a sense of low personal accomplishment. They also rated significantly higher in depression screening. Over 50% of the respondents reported feeling moderate to severe physical fatigue. Medical students also demonstrate pretty significant depression stigma. Greater depression severity scores on the PHQ-9 are associated with lower levels of help-seeking behaviors, which means that these individuals often only come to care in a crisis. Schwenk's group looked at they invited over 700 medical students from the University of Michigan in 2009 to take a PHQ-9 to rate their depression, and then they matched it with attitudes about several statements about stigma of depression. And you can see here, these numbers represent the percentage of those groups that agree with these statements. And I'll read these three statements and their corresponding agreement rates with the moderate to severely symptomatic group. If I were depressed, fellow medical students would respect my opinions less. 56% of those with moderate to severe symptoms agreed with that statement. 83% agreed that faculty members would view me as unable to handle my responsibilities if I were depressed. And 53% thought that telling a counselor I am depressed would be risky. That latter point ties into the idea of disclosure of treatment when it comes to application for licensure. In 2018, there were 200 medical students at the University of New Mexico who responded to a survey that looked at stigma and disclosure of treatment. And 51% of those who self-perceived that they had a mental health diagnosis stated they would not disclose their treatment history on an initial state licensure application. The top 3 reasons that they gave for this non-disclosure are listed here. Of note, in the same study, 47% of the respondents perceived a subjective decline in their mental health during medical school. Medical students and all college students have several barriers to psychiatric services that can keep them away. I wanted to highlight this study that looked at 1,600 college undergraduates who presented to primary care clinic and screened positive for depression screening. They asked that group about a number of barriers that kept them away from their care. And here are the responses related to subjects. You can see that almost 50% of those who were not receiving care but had significant symptoms said that access barriers or feeling that they didn't have time were keeping them away from care. They then did a latent class analysis to look to see if they could identify some profiles of these respondents. And they found a couple of these kind of came together in responses. So they were able to identify that there's a profile of those who experience logistic barriers, and then others that experience what they referred to as psychological barriers, which I labeled stigma and mistrust here. We're trying to use as much of this information as possible to improve our services through student health and well-being. Just to give you a quick background about our teams and our organization, Student Health and Wellbeing is part of University Student Services under the leadership of Vice Provost Kevin Schallenberger. We're an available service to 19,000 eligible students at Johns Hopkins, the qualification being folks who are enrolled in a full-time degree-seeking program. There are 2 clinical entities of Student Health and Wellbeing, our mental health services team and our primary care colleagues. We also have some fantastic collaborators from health promotions and student disability services. The latter group sees about 8% of Johns Hopkins learners. Our mental health services team has a suite of options to meet all sorts of different presentations and really try to focus the patient's idea in centering our care design. We don't charge for our services, and in the past couple years we've unified to be one team with 3 different locations, newly opened in DC, but also just down the road here, like off of Eager Park. In FY25, we saw almost 3,300 unique patients. That's about 17% of the eligible students at Johns Hopkins. That was a 13% increase from the year prior. I really want to speak to the hard work of the psychiatry team here. There should be some familiar faces across the bottom here, where actually all of these folks have worked in Meyer or Bloomberg in their career. So we have a team of 9 currently. Most of last year, we had 5.2 FTEs. We had over 1,100 unique patients last year, and increased our scope and our service by 47% clinical encounters over the prior year. This trajectory is a testament to their hard work, their clinical expertise, and their diligence to really meet the needs of our students and learners here. In the last 90 days, you can see that they've continued this upward trajectory to really try to meet as many folks as possible. 199 new patient evaluations in the last 3 months. Lastly, I want to highlight another feature of mental health services, which is our BHCST, Behavioral Crisis Support Team. This is the country's first on-campus 24/7 clinician staff dual responder model. I would encourage folks to take this phone number down or hit that QR code, because this is something that can be applicable to anybody here. 25% of our calls come from interested third parties, and 75% of the access line calls are people calling on behalf of themselves. But not only do they respond to folks on campuses, but they'll go to the community to meet people where they're at. If a mobile crisis dispatch is called, it sends a licensed clinician along with a crisis intervention trained public safety officer in a vehicle to meet the person where they are. And this is one way that we facilitate the leading edge of our collaboration with the department here, because Dr. Majors and Dr. Rafia Prince have been fantastic in building a partnership that allows us to bring Hopkins students and learners here where they're taken care of as one of their own. The MedWell Clinical Outreach Program is the specific initiative that I intended to speak about today. This has been a partnership that was started with Drs. Credian and House to try to reach students from the School of Medicine. First-year medical students, or actually all medical students, recognize an increased need to address their mental health care. And they've had positive experiences with MHS, but not everybody was aware of how to access these services. So we created a system where we have brief assessments, 20 minutes, with first-year medical students and one of our clinicians from our psychiatry team as well as counseling, where we can check in about their mental health experiences, hygiene practices, how they're managing this major life transition, and also to ensure that they know about what we're doing so that we can try to address that concern about low help seeking that we see more in these populations. These were not mental health psychotherapy or treatment visits unless the individual wanted to have a referral into care, at which case, with their consent, we could turn it into a clinical triage encounter and send those referrals in that moment. We piloted this project last year in 24, and we had some pretty limited engagement, to be fair, and a lot to learn from this experience. Of the 134 then first-year medical students, we had 24 completed checks, so only 18%, and 5 referrals in for treatment. But the non-participant survey was really helpful for us to understand how to meet their needs further. The most common factor for somebody deciding to not participate was that they felt they were too busy, and 4 of the 21 non-participant respondents said that they were concerned about privacy matters. So learning from the literature in this pilot, when I got more involved this past spring, I came up with this plan to address these specific items and barriers to treatment. The logistic barriers that we've kind of learned about already and have heard in feedback, but also to address stigma and mistrust issues and any concerns about privacy. So since last year, we serendipitously rolled out 24/7 available online self-scheduling in our patient platform, which is really helpful for addressing that logistic barrier. But furthermore, the introduction to this program this year came from me through a secure message in our patient portal that arrived in their inbox. It just said, you have an important message from Student Health and Wellbeing with a link, and that actually took them through the single sign-on process into our patient portal to really kind of ease and introduce people into the best way for them to communicate and set up appointments with us, should they need it. We also moved it earlier in the term before the academic workload really built up. To address stigma and mistrust, we were able to negotiate being, I think, the only campus partner to speak to first-year medical students in person at their peer-led orientation process, which helped twofold. One, to be able to be the face of this program, but also our introduction came with an endorsement from the second year who was hosting the program. It really went a long way towards building that trust. And then the messaging further about reminders about this program and engagement beyond that came from me through our secure message portal, with very limited communication about this effort from the academic team. So we were able to really emphasize the difference between our wellness efforts and their academic trajectory. We had a much more robust response this year, where we had 49 of the 117 first-year medical students have a check with us. So that's over double the engagement as previously. 22 of those 49 converted into a triage visit with referral for treatment with individual therapy, psychiatry, or clinical case management to facilitate a referral into the community. We also set up 6 to have their medications managed by primary care. That's for stable doses, antidepressants or ADHD medicines. And 3 accepted referrals to Timely Care, which is a third-party telehealth provider that Hopkins students and learners can have 12 visits for free annually. It's a good option for folks that either want to keep things completely separate or be able to schedule nights and weekend visits around their schedule. Our non-participant survey had 25 responses, and 3 actually declined participating in the program because they were already set up with our service at that point. We had 0 responses that expressed any concerns about privacy, and the most common factor in people deciding not to participate was that they felt they were already aware about our services. So at this point, after 6 weeks, we had 31 or 26% of the first-year medical students having touch points with our student health and well-being group, not counting the MedWell visit itself. Our engagement for individual therapy or psychiatry after 6 weeks is at a higher rate than the current second-year class who've been here for 13 months. And after just 6 weeks, we've had 12 first-year med students have a psychiatry appointment. Satisfaction survey had a couple of responses that I wanted to highlight. I think it's no surprise I would be particularly happy to see that second one about our destigmatizing efforts. And then related to feedback, all those who participated agreed that this brief interaction gave them more motivation to focus on their health. We had overwhelming support to the suggestion that we could offer this in the future as well. So future considerations for this project and beyond relate to trying to figure out really what the right figure for engagement of medical students is. I think it's not totally clear from the literature that this is, if there's a specific benchmark to go for, but perhaps this is a much more dynamic factor that changes through that medical education journey for folks. I think an analysis of chief complaint might highlight specifically if folks were coming for treatment of a mental health disease, life experience processing, or a combination of both, because as we heard, these experiences oftentimes interact. Furthermore, I really want to think about how we can scale this effort. Medical students are a small percentage of our total eligible students, only 600 out of 19,000. So thinking about ways where we can try to consolidate this effort and expand it, I think that house staff would be a great group for us to try to reach. And there's also interest from other academic programs, specifically School of Nursing, to try to reach them in the similar kind of way. Here are the list of references that I used to craft this. I think it's best if you're interested in this that you can message me directly. My email's here. Of course, I'm in JED. That's a 1, not an L. I'm happy to receive questions.
Thank you, Dr. Heffernan. That was a great presentation. Really well done.
Thanks.
And interesting. One thing that I've wondered about is this issue of the relationship between your services, or let's say on any college campus, the services that are provided, and the care people are getting outside that is the care that they were getting before they arrived, and in some cases may continue to get. So, in other words, that issue of handoff and/or coordination seems like a tricky one. So when you're, it seems like maybe in a perfect world, all the people who are new students would have all of their treating mental health providers send, all the information they have to you all, so that to maximize the ability to coordinate. How do you deal with that sort of issue?
Well, I like that idea, and I've batted around like how to come up with a universal type screening for folks who have had treatment already. We haven't rolled that out just yet, but we do something similar for folks who come in and they're taking a stimulant medicine, because a lot of people have been prescribed by their primary care providers or could transition to one. So this is actually an opportunity that for us to really streamline engagement with prior prescribers. We have a form that can be completed. It's like a built-in ROI that gets sent to the prior prescriber, and it asks for some really quick, detailed information about how'd you make this diagnosis, what have you tried, what's the last prescription, did they feel like, would you continue this dose if you were continuing to see them? And that really helps us to kind of triage and find that right fit if somebody needs to come and see a psychiatrist for further evaluation and treatment. If they're stable and are just looking for refills in state, then they can see one of our colleagues from primary care. But expanding this to kind of all mental health care, I think, would be really valuable and help us keep track of folks who aren't necessarily engaged with us for direct treatment for therapy or psychiatry, but might be likely to call our access line for crisis.
Yeah, interesting. Thanks. Other folks have questions? Dr. Bienvenu.
That is different now. So about 2.5 years ago, we ultimately went through with like a full, redesign, where we're now one team with multiple sites. So what that means is that we're kind of leveraging our collective knowledge with regular meetings among our psychiatry staff and our broader mental health services staff. But it's also facilitated us to do things like open up access to whichever clinic people prefer to go to, what's most convenient for them, as opposed to what they were assigned to. It was actually, even though she lives over here and has half of her coursework here, she was assigned to the Homewood Clinic by this old system. Whereas now, if you were coming to engage in care, you would be able to see people whatever felt most convenient to you. So that's one thing that we've really tried to do to decrease that other barrier as well.
Great, thank you. Other questions? Dr. Taylor.
Yeah, thanks for that question. I think the biggest thing that we do to differentiate ourselves is that we use a completely different medical record. So we use a medical record that's designed for student health settings. It's called Point and Click, and it actually imports data from the registrar's office. That helps us keep track of eligibility criteria for that kind of foundational element of like whether somebody can come to see us. But it's really convenient also that when people come for their first visit with us, they have no forms to fill out because we have all of their demographic data. They're connected to single sign-on. So we can just pull and import that information and get right to the work that we want to do. So I use that specifically to emphasize the difference that we have as far as keeping our information private. So even if, somebody who works here in the hospital who's used to Epic, they won't see their work in Epic that they do with us. The other thing that I would say is that, the legal issues about privacy and on-campus health is a pretty muddy waters about what's a FERPA-covered entity and what's a HIPAA-covered entity. And we've moved to be a HIPAA-covered entity, and I think that goes a long way as well, so that people can understand the level of privacy that they're experiencing and can expect.
Dr. Margolis.
Yeah, that's probably the biggest clinical challenge in working in this setting. Because it's not just when eligibility ends, but folks who are spending extended periods of time away from Maryland where their providers are licensed. So we have a couple ways that we can help with that. One is that we've got a fantastic clinical case management team that can meet with folks and help them understand how to meet these resources. And they have guides specifically for people who are staying local but won't have eligibility with us. It's a conversation that I start with people months in advance so that they can know what to expect when they're transitioning to their next stage in life. But we also make sure that there's a safety net for folks. So I mentioned Timely Care as this third-party server that we work with. Students and learners are eligible for that for 6 months after their culmination of their degree with us. And they have license to provide care in all 50 states. So if somebody's moving to California and they have a major depressive disorder, they can see that person during that transition phase or while they're waiting to connect care with a local provider.
That's a really great thing. 6 months of guaranteed transition opportunity. Yeah, that's great. That's great. Dr. DePaula.
Yeah, so we have a pretty robust outreach group. We have a director of outreach as well who works with trying to set up liaison events at student fairs and orientations and those types of things. His name's Dr. Walker Tisdale, and he's been a great addition to our team recently. But on top of that, we also have specific coordinators within our staff who are specifically aligned to liaise with different student groups. Sometimes it's related to an educational program and sometimes related to one's life experience or identity to be able to kind of meet those needs. So between those, our coordinatorships and our outreach efforts, that's how we try to reach those folks. But I think I do share your overall concern with a number of folks who are coming to our campus and might not, or they might be coming with their own ideas about mental health care or, varying experiences of what they've had for care in the past. So it's definitely a challenge to connect with those folks and make sure that we're getting them on the right track to complete their academic journey.
Interesting. Other folks? Dr. Swartz.
Right now, we are experiencing a longer wait time for psychiatric care than typical. most commonly, we're at about 2 to 3 weeks. But we've had such an influx, and it's in some part because of the MedWell program that we're now extended out beyond 6 weeks at this point for a psychiatric visit. If folks are identified as high risk based on a CSSRS that's done through a triage visit or a counseling visit, then we do have avenues to make sure that we meet those people sooner, so that those high-risk folks don't kind of fall into waiting in line and not getting what they need.
Well, related to that, since some of us here might well wind up encountering trainees who need care and maybe sometimes need urgent care, I suppose that obviously if it's a true emergency, they should go to the emergency room. If it's an urgent situation but not quite emergent, what is the point of contact there?
Well, our crisis support team's really fantastic for urgent issues as well. So, and they can be an avenue for people to introduce themselves to our care.
Right. You talked about that crisis team.
Yes.
And so now, is that crisis team meant to only handle issues that occur on the campus?
No,
they'll go out to people's homes.
Really kind of expanding beyond the Hopkins footprint. So they'll go to people's homes as far away. I've known them to go to Anne Arundel County to meet with somebody who was at their parents' house. So they'll go out as best that they can to meet people. And they're not just to, be a transport to the ER. In fact, their goal is to try to avoid that. So they're really, focused on kind of acute de-escalation techniques and crisis intervention to try to keep people on track and out of the ER.
And so have there been many examples of that being used on this campus?
Oh, yes.
Like in the
so there was
dozens
270 dispatches last year.
on the medical campus?
On the medical campus, I actually don't know the number specifically, but we actually only rolled out our expansion to East Baltimore last October.
Yeah, that's why I was
thinking. So we're just
thinking.
filling in at 1 year right now.
Right, and that's why I was wondering what that experience has been like. And so it's been used.
Yes, certainly. Enough
Okay.
that we have a crisis member who is oftentimes here on the East Baltimore campus in the 550 building.
Ah, based in the 550 building. Okay. Some of us work in the 550 building. It'd be good to, maybe it might be good to connect with that person. What's the name? Do you know? Do you know who that is?
It's a rotating group of folks.
It's rotating. Okay.
Yeah.
Okay.
But we do have a workspace, I think, on the 4th floor.
Okay. Interesting. Other questions, comments, thoughts? If not, thank you very much for a great grammar.
Thanks for having me.